really great. Thanks, Emma.
Okay, thank you. I just wanted to just quickly go over again what we mean by pregnancy of location. So it's when a woman comes in, she's got a positive pregnancy test, but we perform a transvaginal scan and we can't see any evidence of the pregnancy. So we've excluded an intrauterine pregnancy and any obvious ectopic pregnancies. So it's not interchangeable with the word ectopic pregnancy. It's not the same. So certainly in the UK, we normally think of a pregnancy of location ultimately ending up in one of three real outcomes. A proportion of women that we scan, that we can't see anything, it may be that we're just too early in the natural history of their pregnancy and we're yet to visualise their intrauterine pregnancy. Also, it could be that they've already had some bleeding, excuse me, and they've actually already had an early miscarriage and now the uterus is now empty. But a proportion of women will have an underlying ectopic pregnancy. Now, fortunately, according to the literature, the majority of women don't have an ectopic pregnancy. Anything between 60 to 90% will either have an intrauterine pregnancy or a failing pregnancy, meaning that about 10 to 40% of your women who you can't see the pregnancy on scan will have an underlying ectopic pregnancy. Now, the proportion of ectopic pregnancies in the women who initially classify as a pregnancy of location will depend on how good you are at picking up your ectopic pregnancies in the first place on scan. So if you're very good at visualising your ectopics on scan, hopefully you should only have about 10% of your pregnancies of location being subsequently diagnosed with an ectopic pregnancy. So I just wanted to go through with what are we trying to achieve in our management of these women that come in who have effectively an inconclusive scan. What are we trying to do? Are we trying to pick out those that have got ectopic pregnancies, because we know that ectopic pregnancies are potentially dangerous, as we know about the confidential inquiries that women still die from ectopic pregnancy? Or are we just trying to diagnose those pregnancies that are failing and that we don't need to do anything about? Or are we just trying to basically identify those women who we don't need to follow up, who don't need any further surveillance? And what are we trying to do as regards follow-up? Now, certainly, I'm still a junior doctor, I work in very busy units, and a lot of these women come back for multiple clinic visits. They have random repeat HCG levels, maybe some progesterone levels, and sometimes it's often very ad hoc when we rescan them. So that some of these women actually, although they only may be 10% of the women you see in your clinic, they're actually a disproportionate amount of workload. And also we're going to reduce intervention. Now, we know certainly in the States, uterine curettage is performed quite regularly in women who have an inconclusive scan. But, should we be doing that? Also, laparoscopy is a well-known intervention for women in whom we can't see a pregnancy on scan. And how about kind of trying to reduce the amount of women that we actually classify with pregnancy of location in the first place? A lot of early pregnancy scan units at the moment will scan anybody with a positive pregnancy test, but we know that women can perform a pregnancy test before they've missed a period. So of course we're not going to be able to visualise those pregnancies if they come in the moment they have a positive pregnancy test. So I just had a little flow diagram here to kind of help with the management of these pregnancy of location. It's normally quite clear what we need to do. If you've got a woman, you scan her, you can't see anything, but she's in pain or she's hemodynamically unstable. It's quite, there still are the cases that need to go straight to theatre. Not very many of them, but it still happens. We may just see some hemoperitoneum on scan. Also happens if they do have some pain and we can't just manage it expectantly, we may need to just go in and intervene surgically. But by far the majority of women who we classify with a pregnancy of location will be hemodynamically stable and may only have minimal symptoms, a little bit of pain or some bleeding. And studies have shown that expectant management is safe for the majority of these women. We normally then end up performing some kind of serum biochemistry to try and predict the likely outcome and try and categorise them into one of these three groups. But it's the timing and which tests we perform where the dilemmas are. So I was asked to talk about serum HCG, progesterone, and rationalising the follow-up. So first of all, if we just concentrate on serum HCG. Now, certainly this is the hormone that I think everyone is most used to using in the management of women with a pregnancy of location. Certainly a single level has well been described as using it as a discriminatory zone. So it was developed with response to transabdominal scans where a single HCG level, if your HCG was more than 6,500 and you couldn't see an intrauterine pregnancy on transabdominal scan, it had a very high sensitivity for the detection of ectopic pregnancy. Now with transvaginal scans, the discriminatory zone level has lowered. So some units use an HCG cutoff of 1,000 or 1,500. But we know that actually using a single HCG level as a way in which to manage your PULs is actually quite dangerous, because many ectopic pregnancies actually have very low HCG levels. So if you're only getting worried about those women that have an HCG more than 1,000, you're going to be ignoring all those ectopics that have probably got an HCG less than 1,000. So it can actually be falsely reassuring. And also you might end up intervening in women with failing pregnancies who often present with very high HCG levels, having had their miscarriage and their HCG declining rapidly. And you don't want to end up performing laparoscopies and things in women who've got a failing pregnancy. What is more useful is the change in HCG over time. Now, this was first developed, or the concept was described about 30 years ago now, where it was thought that the minimal rise of HCG over 48 hours was 66% for an intrauterine pregnancy. Now, more recently, Kurt Barnhart's group have described that minimal rise is about 53%. But if you're using a cutoff in which to exclude an intrauterine pregnancy, you're probably going to be using a much more conservative limit, and 35% has been described. Also have been described of the pattern of HCGs that you'd expect in a failing pregnancy. Now, a decline of anything between 20 to 35% has been shown in failing pregnancies, and the rate of decline often depends on how high your initial HCG level was. But what is less clear is the pattern of HCG in ectopic pregnancies. Again, Kurt Barnhart's group in the States have spent a lot of time trying to do HCG curves and everything for the behaviour of HCG in ectopic pregnancy. And what they have found is that, unfortunately, in about 20% of cases, the HCG behaves exactly as it would do in an intrauterine pregnancy. In about 10% of cases, it behaves exactly as it would do in a spontaneous miscarriage. So then you've got this group in the middle who have HCGs that basically just misbehave. So they don't go up high enough for an intrauterine pregnancy and they don't decrease quick enough to be a failing pregnancy. Now, the other thing about HCG levels, they have been incorporated into mathematical models. I'm not going to go into that, but they can be, using the HCG at 0 and 48 hours has been used in a mathematical model to predict the different outcomes at 48 hours, and with relatively high sensitivities for all the different 3 pregnancy outcome groups. So that's just a quick run through of HCG. Moving on to progesterone. Now, serum progesterone, lots of studies showing, and certainly by Banerjee back in 2001, they showed that an HCG, progesterone level of less than 20 was highly suggestive of pregnancy failure. It basically had a positive predictive value of 95% to predict pregnancy failure. And also we know that high progesterone levels, such as greater than 60, are strongly associated with viable pregnancies. Now, Ben Mole in 1998 performed a meta-analysis of 26 studies looking at progesterone and actually found that it was good at discriminating between a pregnancy failure and a viable pregnancy, but what it wasn't good at was determining pregnancy location. So you couldn't use a progesterone level to predict an ectopic pregnancy. So progesterone is good at viability, but not good at predicting where your pregnancy is. Now, recently, Davor's group assessed a progesterone-based algorithm for the management of PULs. Okay. So they came up with this protocol here, so that if your HCG was greater than 25 and your progesterone was less than 20, it was highly likely you had a spontaneously resolving pregnancy. And you can see just the different groups that they use. So, for example, if your progesterone was more than 60 and your HCG was less than 1,000, that was probably indicative of a normal pregnancy, so they could rescan when it was thought that the HCG was more than 1,000. If, however, the progesterone was greater than 60, but the HCG was more than 1,000, they thought that an ectopic pregnancy was highly likely. And using this protocol, they actually found that intervention rates in those women with low progesterone levels were actually very low. So we can see there that progesterone is good at viability. Now if we look at rationalising the follow-up using some of these HCG and progesterone levels. Now, as I've said before, women with pregnancies of unallocation often undergo a protracted period of follow-up. Repeat HCG levels, the timing of them is certainly very ad hoc, although we normally say between 0 and 4, take one at presentation and 48 hours later. We know that the second HCG often isn't taken at 48 hours. Someone might have taken one at 24 hours, another one at 72 hours. Also, people don't tend to know when to repeat the scan. When should you repeat the scan? Should you do it after a week, or should you wait until the HCG is more than 1,000? And another problem is that results are not always interpreted by staff understanding serum biochemistry in pregnancy. Certainly in the UK, I think a lot of our hospitals, we don't get HCG levels back till later in the day, by which time all our nice people in the early pregnancy units have gone home, and it's the on-call SHO or someone who's left looking at these HCG levels and not knowing what to do. And so what do they do when they don't want to know what to do? They just repeat it. And so before you know it, these women have had multiple levels taken. So George Condis, back in 2005, tried to develop a single visit strategy to try and predict or trying to rationalise the follow-up to see whether it was possible on one visit to categorise women either into a low risk of ectopic pregnancy or a high risk of an ectopic pregnancy, and to see whether if this low risk group we could actually just discharge them on an initial visit. Okay, and then obviously concentrate all our follow-up visits on those that we thought were high risk of ectopic pregnancy. Ectopic pregnancy thought to have been the main concern because that's potentially life-threatening. So the low risk group were those who had a progesterone less than 10 or an HCG less than 25. And they thought they had probably failing pregnancies. And those with a progesterone of more than 50, it was thought they were probably intrauterine pregnancies. The high-risk group were those that had a serum progesterone between 10 and 50 and a serum HCG of greater than 25. Now, unfortunately, in the study, there were 518 pregnancies of unallocation. Fortunately, the study correctly eliminated 84% of the non-ectopic pregnancies from further follow-up, which sounds quite good. But unfortunately, 2/3 of all the ectopic pregnancies would also have been discharged without adequate follow-up, because they were probably in the group with the progesterone on the 50. Okay, so based on this one single visit, it wasn't possible to rationalise the follow-up on a single visit for all three outcome groups. So more recently, we developed a model, using our HCG model, we developed an algorithm based on using a predicted outcome at 48 hours to try and rationalise the follow-up. So we did this prospectively on 364 women. So basically, our women came in at time 0. They were obviously diagnosed or classified as having a pregnancy of unallocation, and they had their HCG levels taken. They then came back for a second visit at 48 hours, where they had a repeat HCG level. These two HCG levels were then put into a mathematical model that predicted their likely outcome of either an ectopic pregnancy, an intrauterine pregnancy, or a failing pregnancy of unallocation. Those predicted to be a failing pregnancy of unallocation, if their HCG had decreased by more than 13% in the 48 hours, they were discharged, thought to be a failing pregnancy. And those that were predicted to be an intrauterine pregnancy, an ectopic pregnancy, were actually asked to come back for a repeat scan on day 7. So the aim was to rationalise the follow-up so that ultimately women with a failing pregnancy of unallocation would have only been here twice for their scan and their HCG on the first visit, and a repeat HCG 48 hours later. And the intrauterine pregnancy and the ectopic pregnancy should have been here for 3 visits: the initial scan and HCG, then the HCG level, and then the repeat scan. And what was interesting is that actually we were able to give 65% of women a diagnosis within 48 hours of the location of their pregnancy. And 89% of them actually had the location of their pregnancy confirmed in the time period according to the study protocol. So day 2 for failing PULs and day 7 for intrauterine and ectopic pregnancies. And actually by day 7, 97.5% of women had actually been given a diagnosis. So after a week of follow-up, only 2.5% of our pregnancies of unallocation were still pregnancies of unallocation. And the intervention rate was only 0.3%. Unfortunately, though, I think about 30% of women actually did come back for additional visits or came back before the specified follow-up time. Because obviously in counselling a woman who's got a pregnancy of unknown location, you have to tell them, I can't exclude an ectopic pregnancy. If you have any pain or bleeding, come back. And obviously there is always the very anxious women that come back before the recommended visit time. Now, more recently, Davos Group again this year have published an evaluation of a single visit protocol for a subgroup of women with a pregnancy of unknown location. And again, a bit like George Condis' study, they looked at defining a group that we thought wouldn't need to come back again. And so they chose the group with a progesterone of less than 10 and an HCG of more than 25. And the plan was if the HCG was more than 25 and the progesterone was less than 10, on that initial visit, the women weren't to come back. And actually, I think during the study, they were telephoned a month later to check if they had actually attended any other service. And they actually did this on 676 pregnancies of unknown location, of which I think 37% actually fell into the group of progesterone less than 10. So you can actually see that's a huge proportion of these women actually fell into this group that are likely to fail. And that fits with a lot of other studies that actually shown that the majority of women with a pregnancy of unknown location, normally about 50 to 60%, actually have a failing pregnancy. Interestingly, only 6.6 actually needed to attend for a further visit. So 93% actually were discharged on a single visit. Only 2.2% of all the women with a progesterone less than 10 actually were subsequently diagnosed with an ectopic pregnancy. And they found that the positive predictive value for progesterone of less than 10 in predicting pregnancy failure was 98.2%. So, if we summarise, so HCG, we know that a single HCG is of no use in the modern management of a pregnancy of unknown location, but serial measurements of HCG at 0 and 48 hours can be useful. Serum progesterone, that is a good predictor of viability, but is not a useful predictor of pregnancy location. But we do know it is good at predicting those patients that will have a pregnancy that will spontaneously resolve. As regard to rationalising follow-up, I think the studies have shown that it is possible to rationalise the follow-up of pregnancy of unknown location. And we do know that a single visit is not appropriate for all pregnancy of unknown location, as shown in George Condis' study, but however it is appropriate for a select group of women with pregnancy of unknown location, so those women with the spontaneously resolving pregnancies. So if we go back to what we were trying to achieve, I don't think we are trying to diagnose ectopic pregnancies or failing pregnancies. I think we are really trying to identify these days which women who don't need any further surveillance. And we should be aiming at trying to discharge those women and then concentrate on those women that we think may have an underlying problem. Obviously, we do want to try and reduce follow-up and also reduce intervention. But what we probably ought to be aiming more of our work now is actually reducing the number of women that we classify as having a pregnancy of unknown location with in the first place. Thank you.